Let's bring our last panelist. I feel like our time is slipping away here, but want to give Hemi her due. Many of you are probably will recognize Hemi Tewarson. She's a longtime friend of the conference and currently president and executive director of the National Academy for State Health Policy, which Sonia teed up so nicely. But Hemi, maybe you can provide some of your perspective on what healthcare leaders might see coming out of the state houses this year.
Yes, no, thank you, Christoph, and happy to be here. And I will speak quickly so we can stay within time. Fantastic discussion. I'm here to talk about what's really going to happen at the state level across the country. Sonia started to talk a little bit about California, but I think in my remarks, I just wanted to reflect that, at the state level, they have to act. Passing legislation, balancing budgets, governors are issuing executive orders. And I think it's a lot more nuanced than at the federal level because actions continue to move forward, even if there may be a political debate going on at the national level or between the parties. I'll also say, I've worked with states for a long, long time. Here at NASHB, we are nonpartisan. We work with all states, red and blue and purple. And there's a lot in the purple category. You have, a Republican governor with a Democratic controlled Senate or House. You have a Democratic governor with a Republican controlled Senate and House. And you have everything in between, both all parties aligned or different parties in House, Senate, and governor. So, it really, I think, lends itself to having to find bipartisan solutions. And that's why I really enjoy my work at the state level, because we always have to move forward. And in our projects at NASHB, we work with insurance commissioners, Medicaid directors, governors, advisors, public health officials, social services agencies, and really, I think, give us a perspective of, wow, there's a lot going on at states, and it's not all about the politics because things have to move along. So next slide, please. So I wanted to, I talked a little bit about NASHB, so we can keep moving along. I wanted to just give you a sense of, where are states moving in 2022? And really, it very much aligns with the conversation that we've had with all three speakers, actually, on a couple of priority areas. And I actually think they match up pretty well with what California is facing as well. So the first category I'm going to talk about is public health. Where are we in public health? Behavioral health, we are seeing mental health crises across the country. And we also are really seeing the increase in overdose deaths. And so both of those together, I think, really amount to a crisis that states have to grapple with individually and collectively. Healthcare workforce, that's topping the list for many states in terms of challenges. It was not top of the list for many years. I've worked in state health policy for a long time, and it really is now emerging. And we saw, we reviewed the state of the state addresses to date from governors, and healthcare workforce has come up many, many times, which was not the case in previous years. Cost of healthcare, that continues to be a really hot topic. Consumers are really concerned about why it still costs so much for things like prescription drugs and also their hospital costs. So there's a lot of work going on at the state level to try to address that. And to Sonia's last point, there really is a lot of work going on social determinants of health and equity. I think we've seen in this pandemic the disparities that have really just been exacerbated by the COVID-19 pandemic itself, and really an acknowledgement that we really need to figure out a way to really support and address some of those disparities in communities. And I will say communities that span all red and blue states alike. Okay, next slide, please. Okay, so I wanted to talk a little bit about public health and what is happening at the state level. And I am going to go through these pretty quickly and high level because I do want to have a chance to have a discussion with all of you. So moving to recovery. Governor Newsom's leading the way here. So a lot of the states now, state leaders are thinking about, we need to move to the endemic. And how do we do that? And there's going to be a lot of pieces to be able to do that safely and effectively, and hopefully without another variant being sprung upon us, which will create a lot more challenges in terms of getting people back into things like isolation and quarantine and masking and all of that. So you're seeing new messaging from state leaders about how to think about the pandemic, what actions we should all be taking, really taking more responsibility for testing yourself and informing those around you if you're sick. A really different approach, I think, to what we've seen to date. And I think that's because we have to. People are tired of the pandemic. They need hope. They want to move to the next phase. We're hopefully towards the downward spiral for good on Omicron, and hopefully we won't see another variant anytime soon. But along along with sort of the moving to recovery, our governors are also ending their public health emergencies. Many have already, many more will do so. And the federal government is going to do that at some point as well. If I had a crystal ball, I was predicting it would be the end of this year, but with everything happening politically, it may be earlier. Some are predicting it may be as early as this summer. And what that means is there's going to be a lot of federal flexibilities unless Congress acts to extend those that will end at the end of the public health emergency. One of those is continuous Medicaid eligibility. States have been keeping folks on the rolls as a condition of receiving additional federal dollars for their Medicaid programs for this COVID-19 pandemic, which means that there are folks on Medicaid that may no longer be eligible. There are folks that, have not been redetermined for, just about 2 years now. And so there is going to be a big shift when we get to the end of the public health emergency and states have an option of starting the redetermination processes. They can take up to a year to do it. And California is a state that seems to plan to do that, but not all states will. So I think there'll be a challenge in making sure that folks understand the redetermination processes, that they're being reached, that they're going to actually fill out paperwork, and that if they're not eligible for Medicaid, they are also directed to other places like the individual marketplaces. The other thing that's going to happen unless Congress acts is folks on the individual marketplaces right now have received a lot of extra help and reduction in their out-of-pocket costs with their APTCs. And if those are not extended, people will see a significant increase in their premiums if they're on the individual market. And that will start happening in October, November when those rates are announced. So a lot happening in 2022 on coverage. I also wanted to just talk a little bit about modernizing public health. So I think, we've learned a lot during this pandemic about the shortcomings, frankly, of public health data systems, the need to modernize those systems, the interest in really getting more transparency around what is happening when you're in a pandemic and you've seen dashboards being put up and vaccination records being shared between, state officials and public health and in Medicaid, for example, and progress that has been made that hasn't been made in the past. What I think needs to happen is states are really thinking about how do we take the federal dollars that are flowing from the American Rescue Plan Act and invest those in areas such as our data systems and our public health workforce to make sure that we're going to be prepared the next time around. But states are approaching this differently. Some states are taking a much more comprehensive look about what to do. Other states are really thinking about, where should authorities belong in the next pandemic? Should the public health official be able to isolate and quarantine folks and order businesses to be closed? So should the legislatures have that decision or be able to end those types of orders? Who should have the ability to decide who wears masks and requires vaccines? And so in this arena, it has become political, and there have been differences among states in terms of how we're really going to look at public health moving forward. My concern is really thinking about what may come next and what public health already does with respect to routine immunizations and, clean water and making sure that people have healthy foods and all these places where public health did its work out of the politics and out of the limelight. And that might get caught up in some of the conversations going on in terms of, where does public health go next? Rebuilding public trust. I think there's an incredible amount of work to do to rebuild the public's trust in our system, our public health system, our state government, and frankly, our federal government. And so at the state level, I think leaders are really trying to focus on how do we better communicate with the public coming out of this, hopefully coming out of this pandemic, and really get back their trust and bring them into some of the conversations and really making more connections to the community, because I think that's going to be needed as we move forward. Maybe we can go to the next slide, please, because I want to keep going. Behavioral health. So there's a lot of interest and need, not even interest, but just frankly, urgency to really addressing behavioral health across the states. A couple of things just to highlight for you all. There's going to be a national 988 line where folks can call in with a crisis and get on a national level and get directed to services. To couple with that, states have to be prepared to have the infrastructure in order to get people to the right places. And so there's a lot of work going on around the mental health workforce and mobile crisis, and really being able to reach rural areas that really don't have the providers there already. There's continued consideration of telehealth, how telehealth can play a role. It really has during the pandemic with respect to mental health services in particular, and how that can continue to be reimbursed after these public health emergencies end and those flexibilities really kind of roll back across the federal and state level. There's a lot of work going on in integrating and coordinating physical and behavioral health. That's been a longstanding goal and interest area, but I do think there's more urgency given the need and the attention that this topic is getting across the states. Parity between public and private insurance. States are really thinking about how do we implement parity requirements? How do we really bring the commercial plans in to make sure that they're able to cover services in the same ways the public providers do? And I think there's a lot of work going on at the state level to really figure out programmatically how to do that. And we'll continue this year. And then a focus on children and adolescents' mental health. So that has just been, it's now a crisis. And I think states are thinking about, we're going to need to be creative in how we address those needs. There are not enough providers, and there's not going to be in the short term. So how do we better equip things like school counselors and having different sorts of community-based trainings and involve different types of folks like community health workers to help us expand our workforce and be able to do more when we don't have enough practitioners. Okay, next slide, please. Okay, healthcare workforce. So I talked a little bit about this already in behavioral health, but even beyond behavioral health, there is a nurses shortage. California, I know, is facing this. Long-term care workforce. We don't have enough folks in those places where we can keep older adults in their homes, which many of them want to do. We also don't have enough staff at the nursing home level. COVID has really taken a big toll on folks who are burned out, early retirement, leaving for other jobs. And there's not a pipeline, an immediate pipeline to really address those gaps. Some of the other areas where I think states are really pursuing to expand the workforce is, I mentioned community health workers. There's some really interesting work going on across states of how to bring in more community health workers to play a role of connector to other services, really trying to meet people where they are, getting a better sense of what the community needs. And so there's states that have really invested heavily in this and will continue to in 2022. Peer supports is also in the substance abuse disorder realm is really going to be, I think, an important workforce element to really extend the workforce for that piece. Family caregivers, we are doing some work here at NASHB on family caregiving. I really do think that's going to be an important piece in all of this because they are going to be needed since we don't have enough healthcare workers for those populations. I'll say the other piece of investing federal and other sources of funds. So ARPA provided a lot of funding to states. States are scrambling to figure out how to spend those dollars. And in one area has been workforce. Now those are short-term dollars, and states always are concerned about having sort of long-term obligations created with short-term dollars. But because of the workforce challenges, some states are deciding we're going to spend the money now and expand the workforce, such as in home and community-based services and in other areas. And they'll figure it out later on how to pay for it because of the crisis. Okay, next slide, please. All right, so I'm just going to talk briefly about the cost of healthcare. There's a lot to cover here, not enough time, but I just wanted to highlight for you, there's a lot going on in both of these areas. For prescription drugs, we were just looking, there's like over 200 bills in state legislatures right now. They won't all pass, but they're across a lot of different areas. Transparency continues to be a hot topic. California has a really good dashboard on prescription drug transparency. Maine is leading with respect to actually using their data to figure out, policy change. And I think a lot more states want to have more transparency in the system. PBMs, pharmacy benefit managers, also a very hot topic. How do we really think about, moving the needle in terms of the middleman and making sure that savings are passed on to consumers directly. Consumer strategies, Sonia mentioned this, insulin caps. That is, I think we have, over 33 bills that are being either passed or considered across state houses right now. People really want to make sure that folks have affordability for insulin, and that I do think will extend to other drugs beyond insulin as well in sort of the next legislative session. Prescription drug affordability boards, that's kind of a method by which to say, okay, how do we really look at drug costs across the board and have controls over them so that we can have sort of references as to what's too expensive and what's not. Colorado and Maryland are leading in that. Washington is a state that could be poised to pass that, and many other states are considering it. International, so there is continued interest in importation from Canada. The FDA continues to move along their program, although nobody is actually live and approved and ready to go. But states continue to pursue that. Can we bring in prices from Canada and actual drugs from Canada and have a lower price? And then there's the reference pricing. There's a couple of states thinking about these bills of, can we actually just use Canadian prices as benchmarks in order to figure out whether our drugs cost too much or too little? On the health system side, I'll just touch on this briefly. Real interest in transparency. How do we understand the data? Health system data is very hard to understand using APCDs and other methods by which to report. There's mitigation of consolidation of market power. There's been a lot of consolidation across the healthcare system, which has led to higher prices. In Rhode Island, just recently, they decided they would not approve a big merger because they were actually able to identify some of the detailed accounting for the systems, and they were able to show that it was going to really increase costs in their markets. Overseeing hospital cost growth. There's a lot of states doing benchmarking. They're really interested in how do we have a cost containment strategy that limits how much a state's healthcare spending can grow each year. Massachusetts pioneered this in 2012. And since then, Rhode Island and Delaware have established programs. Connecticut, Oregon, New Jersey, and Washington are implementing programs now. Pennsylvania, Nevada, and California are considering it and thinking about it. So I do think there are going to be more states coming on board. Oregon, interestingly, is the only state that has the authority to fine entities who are identified as exceeding the state benchmark, but lots more to come on that as well. And then maybe next slide, please. Just really briefly, in the last minute I have is equity and social determinants. I won't do it justice, but there's a lot of work going on in the state level, on the state level, on both of these categories. With equity, we have states that are creating governance structures where there's cabinet level officials who are going to ensure that equity is sort of infused across the agencies. Some states are declaring racism as a public health emergency. Other states are viewing it a little bit differently, where they're just trying to coordinate action across state agencies, or they're thinking about incentivizing equity through payment for and delivery of care. And other states are using different terms and really not really calling out racism and really thinking about things such as disparities and how do we address those. On the social determinants of health side, I think there's a real interest in connecting to communities, figuring out the roles of CBOs, expanding their roles, identifying ways to share data and funding across state agencies, things like housing, and food insecurity and child welfare. How do we connect those systems back to Medicaid and make sure that everybody can understand the whole person and really provide that kind of care? I think there's some interesting payment and delivery reform efforts going on. There's interest in a couple of states to really move to population health measures. Oregon just announced a kindergarten readiness measure that's going live. It was piloted last year. It's going live in 2022. So I think there's continued interest in how do we really think about healthcare more holistically. I think at the federal level, there'll be some interest in being creative around that. It is a priority of the Innovation Center and CMS more broadly. So in both of these buckets, I think there's going to be opportunities for states in 2022. Okay, last slide, and then I will turn it back to Christophe. I just want to mention here, we're having a lot of elections. We talked a lot about the midterms at the federal level, where there's a lot of elections at the state level. There are going to be 36 states that are electing governors in 2022. 8 of these states are guaranteed to result in a new governor, and I think a couple others will as well. So just wanted to show you this map, because this year I think is going to be defined by what are going to be the topics that some of these governors are going to campaign on, and what are they going to want to be able to accomplish before they head into their election cycle. So maybe with that, Christophe, I'll turn it back to you so we can have some discussion.